I have here one or two questions already from the chat room. First question is to Professor Prashant. Prashant, stand by, you have a lot of questions for you, but one of the questions, and everybody remembers your condom theory in regards to morcellation on the fibroid and bagging the fibroids before morcellation. They remembered what you say about the condom. Can you please repeat that to everybody?
Well, if one is contemplating doing a laparoscopic myomectomy and then trying to bag and morcellate it, you're actually parking that fibroid on the bowel before you can put it in the bag. So with the result that the time that is spent, you already upstaged the disease. The movement of the harmonic scalpel on the tissue, or even if you're doing electrosurgery, causes micro tissues to fly around, as you would see when you are using the harmonic on the fibroid. So even the act of enucleation is kind of spreading the disease if it's a leiomyosarcoma. So this is akin to using a condom after the act of sex. The pregnancy cannot be prevented. That was my take. It's not actually my take, it's my son's take, and I copy his sentence. So let's give the credit to Abhishek. The son teaches the father on how to use a condom.
Yes, but yes. Prashant, you are the president-elect, and I'm glad you voiced your opinion because that's very important to a lot of us in Asia doing myomectomy, not using the bag, because many of us believe the risk of sarcoma is very low, and also
it's very low because I fail to understand how the FDA got a 1 in 350 incidents of leiomyosarcoma in their series. And I'm sure with all the people who are sitting out there across the world listening to this talk or participating in the talk, I'm sure we do not have that kind of an incidence. And if you look at literature, it goes to almost 1 in 10,000. And the largest series that was described by Bernd Boyer from the Charité Hospital in Berlin, he had 34,000 plus hysterectomies that were done in their center, and they only had 4 patients of leiomyosarcoma. Now, the thing is that if a patient has leiomyosarcoma, whether you do a laparotomy or a laparoscopy, you have already upstaged her during the time that you're enucleating the fibroid. If you were to remove the entire uterus in toto, possibly the spillage would be less. And there has been a study that was published in the JMIC journal that showed that if you aspirate the peritoneal fluid, even before taking the incision on a suspected leiomyosarcoma, you would get the cancer cells lying around in that fluid. So therefore, this theory of the morcellation causing upstaging of the disease in the way that the FDA talks about is a little too far-fetched. Of course, I'm not going to say that, well, if it's a leiomyosarcoma, go ahead and morcellate. You do not morcellate if it's a leiomyosarcoma. A rapidly increasing size in the fibroid is one that...
Yeah, my topic spikes up.
Yes, please continue. Have you finished?
A markedly vascular fibroid or your LDH levels are high, or any of the parameters that would be there to suggest a leiomyosarcoma, do not do a laparoscopic surgery. Go and do an open surgery on her. But then you know that it's a calculated risk even when you do a surgery on her by open technique of a laparotomy, that you're probably going to upstage if you're just going to do a myomectomy. So these are things that one has to keep in mind. What is very important also is that you need to do a good lavage. You need to keep the head end of the patient up and then allow all the fluid to drain. You irrigate profusely. You may even spend 10 liters of normal saline or ringer lactate doing the flooding of the pelvis. And then you will see that there may be small tissue bits that literally come out from the hiding. and you need to retrieve them very well. So therefore, that's the take on morcellation. I do not like to use the morcellator, not because of FDA. My problem is my incisions are always 5 millimeters. And if I try to use a morcellator and I go up to 12 or 15 or 20 millimeters, as some people have, it's a very painful incision in the left lateral quadrant. On the other hand, if you follow the philosophy of Qilong Li and Wang, who described the Changung method of getting it through the umbilicus using the retractor from Applied Medical, that is the wound retractor. You use an extra small size. You can make a 2 centimeter incision, expand to 4 centimeters, and you can now remove the fibroid by chopping it through this incision very well. I can show a video of that if one wanted to, but that's the technique that has been developed in Changung, and then you reconstruct that umbilicus back to normal. It looks absolutely normal. So that is much better than using a morcellator.
Okay. Thank you, Prashant. There you have it. Yeah. The President-elect of APAGE has spoken. That is a great relief to many of us, and the majority of us still find it troublesome, cumbersome, and in fact, really does not really mitigate the spread, does not really mitigate the spread of the sarcoma, because the moment the knife is down, it really spread the sarcoma. Let me just read to you. Someone just sent to me on the recommendations during uterine morcellation. And I've read a lot. This is perhaps the best given by Society of Gynae Oncology in December 2013 from USA. And this is one statement which I would like to share. That no reliable method is currently available to differentiate benign from malignant leiomyosarcomas or stroma sarcomas before they are removed. Furthermore, these diseases offer an extremely poor prognosis even when specimens are removed intact. So there you have it. What the oncologist says that even you remove it intact, you would have probably spread the disease the moment the knife is down onto the serosa layer. And I think this is very rational, very reasonable. Thank you, Prashant. Now, the next question.
Hello, Prashant, can you hear me? This is Dr. Kevin.
Yeah, Kevin. Hi, Kevin.
Hi, I have my own views on this. First of all, leiomyosarcoma is not something that cannot be diagnosed. Little high index of suspicion at time of surgery. Almost all cases, you can have a very high index of suspicion. Now, what I do in my practice is, if I have a feeling that this could be a leiomyosarcoma without doing any morcellation before, in fact, even before I do the enucleation, I first take a biopsy of the fibroid and send it for frozen section. By the time my myomectomy is complete, I have a report from the lab, whether it is a leiomyosarcoma, just a leiomyoma, or leiomyoma with increased mitosis. All the diagnosis is in front of me, and I make an informed decision whether to counsel the patient relative to go ahead and do a hysterectomy with a leiomyosarcoma or increased mitotic. I definitely put it in a bag. In fact, in my practice, any fibroid more than 4.55 centimeters, I always put an endo bag. And I don't agree with you about the condom after use, because what you're forgetting is when you're doing a myomectomy, you're cutting into the uterus and upstaging. I fully agree. But when you're morcellating, Prashant, you're using a revolution speed of 33,000 per second. Now that's like you making a milkshake in your liquefier and not putting the cap on. You can imagine what is going to happen to your kitchen.
No, whether you use a morcellator or a knife, you're cutting into malignant tissue, right? And if your point of saying that you're going to send it for histopathology and then it turns out to be a leiomyosarcoma, you've already gone ahead and done your myomectomy, enucleating the fibroid and caused further spillage. You're already upstage at that time itself, and your parking of that fibroid on the bowel has also upstaged. It's not that you're parking it in a bag. before
No,
you
no,
can
I fully
put the
agree.
bag in.
I fully agree. I fully agree what you're saying. I understood what you're saying. But my point is the difference between just parking and you know, doing a morcellation like you showed in your video without a bag. I don't think that's advisable at all. Because, you know, it's like going for a walk in the rain by parking it there, and then going for a walk in a cyclone when you're just morcellating and letting, you know, the fibroid mince at such a high revolution speed.
Let's have how many leiomyosarcomas have the entire group who's listening and contributing to the discussion today have had leiomyosarcoma out of all their patients, right? So it's just that for that one patient, one should have had a high index of suspicion at the beginning clinically itself. The woman's
correct. I agree with you. I agree with you about that.
And then if it's leiomyosarcoma that you say that you're taking a biopsy at one end, you're not taking multiple biopsies, and therefore if it's missed at the other end of the fibroid, you still have missed the boat.
No, anyway. Leiomyosarcoma is not a segmental disease. If it's there, throughout the fibroid. I'm sorry.
Okay, there are lots of questions coming. I think Dr. Manjula has something to say. My panelist.
Thanks, Prashant.
Dr. Manjula.
Thank you, sir, and thank you, Dr. Kevin. But the point, the proponents of the contained morcellation, most of the time it is not about upgrading of the sarcoma, because we all know, like sir said, it is going to be upgraded. But basically because of the splaying of the tissues, which can actually spread it into the multiple corners. But listening to the tips and tricks of Dr. Prashant, when he said you have to decrease the RPMs which you are doing and see that you don't pull the tissue into it against the resistance, I think that tip goes a long way in against the splaying of the tissue. So, but the proponents of the in-bag or even the contained morcellation is against splaying rather than the upgrading. And it makes it easier at the end to take out very small bits from everywhere to be taken and not to be left over, so that we do not end up with parasitic leiomyomas. Thank you, sir. Prashant, sir, it was a great talk. And even Dr. Choi.
Thank you very much. Can I just add, we have to move on. A few ideas came out. Number one is, must remember, not every operating theater in the world has a frozen section facility to do that. You are very privileged to have that facility. Second, you think about it. When you approach a myoma or fibroids, why do you want to do laparoscopy? Isn't that you believe in all goodness, to be fair to a patient, that you believe 99.9% or 100% that it's benign? Because if you ever thought that it is going to be a 0.001% chance that it is not going to be benign, or it is sarcoma, then you should not be doing laparoscopy. You should not even think of using the bag, right? I mean, if you want to do a bag, means you're not confident of your diagnosis of it being benign. Okay, but that is food for thought. Okay, another question. Can I move over to my elegant lady co-panelist, Dr. Manjula? Dr. Manjula, I know you're about one of those rare, talented gynecologists who has done MRI HIFU. Can you tell us your experience? Because many of us have no experience in this. Please tell us your experience. And at the same time, I know you're very well read. Can you please summarize or explain the salient points of the NICE guideline?
Thank you,
Thank
Dr.
you. Over to you.
Thank you, Dr. Lee. See, MR HIFU, when it just came to India, we started using it and promoting it, but we had our own fallacies, negative points and the positive points. Yes, like you said, and like Dr. Choi said, every patient wants a minimally invasive or non-invasive or scarless surgery if given an option. But saying that, every hospital, especially the multi-speciality hospitals, have an MRI machine which is fixed for so many other things. So we had to wait for a time slot, which can be different timing as that of the regular days, or in the evening 5, after 5, or a Sunday. Second, we are at the whim and fancy of the radiologist who has to take care of the MRI. And then other things which were coming in our way was, or not all the patients were fit for MR guided thing. So taking it out, even the costs were almost similar to that of the open or laparoscopic surgery. So being a surgeon ourselves, like minimally invasive surgery, we have always had a thing that it is easy for us to
Oh, I lost you. Manjula, we lost you. Can somebody, can organizer do something about this? We lost Dr. Manjula. No, we can't get Dr. Manjula. Dr. Manjula, I'm so sorry we lost you. No.
Hello?
Manjula, you're back. You're back. Can you, I'm so sorry we lost you. Can you just repeat?
Sorry for the connection issue. Yeah.
Now it's okay.
Yeah, we did have cases where patient was immediately very happy. The satisfaction rate was good as far as the bleeding is concerned. Satisfaction rate was good as far as the pain was concerned. But the size, when they start, psychologically, the patient was not happy much, because after 3 months, they do a scan. After 6 months, they do a scan. The fibroid is still there, but otherwise they were okay with it. And some of the patients we had to, because of the extrusion of it into the intracavitary, as an intracavitary lesion, and then coming out through the vagina, they would come back to us with the bleeding and with the necrotic tissue coming out through the vagina. So that was something which was we were not very happy to deal with. And slowly, being a minimally invasive surgeon, we stripped over directly to the laparoscopic surgeries and all that.
What about NICE guidelines, my dear?
NICE guidelines, like we all know, Dr. David is somebody who has been very pioneer into doing it. So it is very clear that NICE guidelines says the patient should be more than 45 years, and we should be looking at least, if they're multiple fibroids, we look at 5 fibroids at a time, and each fibroid at a time is what we are looking at. And the cutoff centimeters should be 10 to 12 centimeter, nothing more than this. So patient who is symptomatic and not having the pressure symptoms, and the more than 45 years, and then 5 fibroids is something which we can look at. And some of the guidelines like ACOG say we can go up to 8 fibroids also, but each one should be tackled.
Again. Okay, let's move on then. Somehow we lost Dr. Manjula. There are a lot of questions on pertaining to sarcomas and MRI diagnosis of, you're back. No, I was just saying there are a lot of questions on sarcoma, MRI diagnosis. How do we know whether it's benign or malignant? Well, let's leave it to
the next. We do not know.
Sorry?
I want to make a point here, Dr. Lee. We do not know, but when it is used for malignancy treatment, we take it for granted that it is used for this. That's it, no tissue diagnosis.
Sure, that's fine. Because like many of us, when we ask our patients, first time you find a fibroid, let's say it's about 3 centimeters, asymptomatic, we ever ask ourselves, is this going to be sarcoma? And the answer is no, and you're willing to watch. Then why are we asking every HIFU practitioner and tell them you're doing HIFU and there's no histology? What if there's a risk of sarcoma? It's the same thing I ask you now, that if you have a 3 cm fibroid, 4 cm fibroid, minimal symptoms, and you ask your patient to, aren't you just as guilty as not having a diagnosis? Okay, anyway, on to the question of sarcoma, MRI, and how to diagnose sarcomas. Can I leave it to episode 2, whereby my Professor Chang Lian will be giving his talk on HIFU, because there will be a specialist or expert in HIFU for every episode, and you probably get all the answers you want to ask.
सोने गई और मेरे को याद आ गया एक मीटिंग था,
Pregnancy.
अच्छा याद आ गया वो मीटिंग खाना खाएंगे?
Giving birth. You can hear a baby in the background. And that's the question of what are the pregnancy rates and outcomes after HIFU. Again, there will be an expert that will explain pregnancy rates and outcomes after HIFU. Back to Dr. Choi. Someone asked, how many myomas can you normally treat, or do you have any criteria in your private practice? Do you turn away patients, or do you have a set guideline to what you accept as a treatable HIFU, myoma for HIFU? Dr. Choi.
Well, I don't think the number is important. I have experience of treating more than 10 or over 10, I think, but usually the guideline made by Korean Society of OBGYN made a HIFU guideline. At that guideline, we usually treat myomas under 12 centimeters by HIFU. I don't know the exact reason why it's 12 centimeters, but I think if the myomas get over 10 centimeters, well, the reduction volume is quite lesser. So I think they are worried about less symptom relief or something. But if in my policy is if the myoma is larger than 10 centimeters, I usually use GnRH agonist to shrink it under 10 centimeters and then do the HIFU.
Thank you. Okay. There are one or two sensitive questions for you, but I think it's important. You are a laparoscopic surgeon. Now, what makes you take up HIFU for treatment of fibroids? It's a general question which a lot of people ask. Why do you switch? Because in laparoscopy, probably you're very well versed, like many of us. But why? Why do you change to HIFU? And the next question is, there are so many HIFU machines in the world. Why do you choose that machine from China? Because in Korea, the technology is very good, very high, and especially you have offers from USA, you have offers from Europe. Why China? Dr. Choi?
Okay, wait, sorry. Question one more time, please.
Okay, sure. I repeat that. Sorry, it's too fast. The first simple question is, why do you choose
HIFU?
HIFU, when you can do laparoscopy, why?
Well, my first reason was I wanted to do a more fancy treatment. To make a less scar or something. Actually, when I was being trained in the Samsung Medical Center, a HIFU machine was adopted at the Department of Radiology. At that time, I just got the idea of the HIFU machine, and after I graduated, I get my diploma. I went out to the field, and I remember that that concept, that treatment, and at that time, around 2010, the Koreans gynecologists had a movement of doing the HIFU treatment in the field of gynecology. So at that time, I was very interested. I remembered the first concept of HIFU when I was in my residency, and I challenged to do it.
Okay, the next sensitive question. There's so many HIFU machines in the world, including Korea, which has the machines, and there are many more machines in China. But why that machine?
Well, actually, I thought about adopting the MR guide HIFU, but as you know, usually the radiologists deal with that machine, and the price is quite more higher, and there are very many applications to adopt the MR HIFU in Korea, and there are quite several kinds of US guided HIFUs on the market right now, but as you know, the Chongqing HIFU has much reports in journals and scientific basis and many cases. That was the reason I adopted Chongqing HIFU.
Okay, thank you. Thank you. I thought it was the Chongqing hot pot, or is because of David Cranston from Oxford. Okay. Okay. Then one or two more questions which I got. One of them, can I go back to Prashant? You're back. Prashant, you're the president-elect, so whatever you say is very important to our world. Okay. What do you think of the use of ulipristal acetate for fibroids? Oops, Prashant, you have muted yourself, Prashant. Or Manjula, you want to say something, Manjula?
Yeah,
okay, Manjula, say something.
Sir does not want to say. Sir, please go ahead.
Well, I don't allude to using ulipristal, especially because in the UK and in France, I think they had cases of liver failure, and therefore the product was supposed to be launched on the 22nd of March in South Africa. One day before, the company called off the release, and because it's been banned. So I think one has to look at it very carefully whether it's A, going to be effective, and two, if it's going to cause these problems with the liver. I would not want to be facing a trial with my patient, then suing me for money that I cannot afford to pay her.
Okay.
Or her family.
I would like to add something.
Sure.
In India, lots of people, especially, in India, lots of doctors as gynecologists, especially in the districts and all, have used these things, because the reason being, again, the patient always wants a medical management. Like sir said, yes, 7 cases of liver necessity for liver transplant had been there, and in Europe it is not used. So what is very important if you are using ulipristal is that you have to do an LFT before, and if it is deranged, please do not use it. And LFT has to be done after 3 months usage of it between the each course. That is very important. So in between and after that, and in my practice, I do not use it. Just like sir says, we believe in removing it. But there are times there is things that.
I lost you again, Manjula. Manjula, we can't hear you again.
And we also
Can't hear me?
Yeah, now.
we can hear.
Can you hear me now?
Yes.
So in my practice, I would be using it only in a very select patients where post-operatively there are seedling fibroids, where the patient is going to come back and tell that you still left fibroids inside me. So even though after counseling, that is the only role we do. Otherwise, like sir said, we hardly use it because being surgeons. But in the districts, they have used. The negative points of using it is it causes we all know it affects the neoangiogenesis and it affects on the fibroid. So it causes lysis and necrosis. So when we are actually doing the myomectomy, that can actually be very difficult to remove the fibroid after doing the surgery. So we do not use it pre-operatively at all.
Okay.
Hugo sitting out there, maybe Hugo can give his German point of view. But I know that the recommendation from the Royal College is that do not, if a patient is already on ulipristal, check her liver function and continue it after counseling her, but do not start any new case on a patient.
Right.
So that's the recommendation last year.
You mentioned Hugo. Hugo is back from his cup of coffee and tea. Hugo, you have to say something. But before that, Hugo, please crystallize your thoughts. You will have the last say because you are in charge of that working group on HIFU for you. Before you, that's one last question. That's one important question. Have patients required to undergo surgery post HIFU?
Huh?
Are the surgical planes more ill-defined? Are the surgical planes poorly defined for patients after HIFU, and if the patient has to undergo myomectomy? Can I pose this question to Dr. Choi, have you had experience to do a myomectomy after HIFU?
Well, actually, I don't do laparoscopic surgery right now in my clinic, but my colleagues who do surgery says that after HIFU, the myomectomy there's more adhesion, so the surgery can be a little bit more difficult. And some doctors say that there's a little more bleeding, but well, I usually can't agree with that because, as you know, ablation makes the coagulation of the vessels, so I think it will be lesser. But I agree with that the adhesion can be more or made with the myometry and the myoma. So the surgeon may be a little bit more harder to do the surgery.
Okay, I have one case so far where I have to go in because this lady has about 4 fibroids, but one of them didn't resolve so well. I have to go in again, but I have no problems with the planes. Okay, maybe over to Hugo. Professor Hugo, can you please unmute? Unmute. Can you hear me, Hugo? Hugo, can you hear me? Hugo? Over to you. Hugo, over to you. I can hear you now.
Okay, hi.
Hi.
Yeah, I followed the discussion all the time, of course. About ulipristal, I just had 3 days ago a discussion with Rudy about ulipristal, and it's, maybe not in the UK, but here in Europe, it's very difficult. So ulipristal treatment for myomas, and especially for patients who have bleeding under myomas, is offline. And it's very difficult to do that because if something is going wrong, you're responsible for it. So I had a few days ago a very important patient here who said to me, we want everything with exception of surgery. And I discussed with Rudy, and we said we cannot use ulipristal. The only thing what we can do is generate analogs. And as at the moment, HIFU is very difficult in Europe. I proposed her now to have a laparoscopic myomectomy or supracervical hysterectomy.
Okay, thank you, Hugo. You're most welcome. There are 1 or 2 questions, but one of them is what type of fibroid you will not do HIFU? Dr. Choi, can you answer that? What type of fibroid you will not do HIFU?
Yeah, pedunculated subserosal myomas are not recommended to do it, to do HIFU, but well, I have several cases of cases that I did pedunculated submucosal subserosal myomas, but there was no problem. They shrink well. I think there's a concern that the pedunculated myoma detaches from the uterus and rolls around the pelvic cavity. But by my experience, there's no cases of that. Yeah.
Okay, thank you. There are lots of questions, but some of them, I think, in the 2nd episode and the 3rd episode, the experts will answer them. And we're going to hear from Professor Zhang Lian and Dr. Raymond as well from South Africa on myomas and HIFU. Can I